Assalamu alaikum. Good morning, everyone. This is Dr. Mibullah. Today I am presenting evaluation of erectile dysfunction. Learning object, epidemiology, etiology, history and clinical examination, investigations. Anatomy of penis. Penis is composed of three cylindrical structure, the pair corpora cavernosa and the corpus spongiosum, which houses the urethra. Both muscles assist in erection. Bulbospongiosis empties urethra after mechanical ejaculation. Suspensory ligament of the penis is attached to the pubic symphysis, which holds the penis close to the pubic bone. Vascular supply. The paired internal pudendal artery is the major carrier of the blood supply to the penis, dividing into three branches: bulbourethral artery, dorsal artery, and the cavernous artery. The cavernous artery supply the corpora cavernosa, effect tumescence by giving helicine arteries to trabecular erectile tissue and the sinusoids. The dorsal artery, the skin, subcutaneous tissue, glans penis responsible for engorgement of the glans during erection. The bulbourethral artery, the corpus spongiosum. The venous drainage of the glans is mainly through the deep dorsal vein. The corpus spongiosum is drained via the circumflex, urethral, and Burger vein. But the drainage of the corpora cavernosa is more complex. The mid and distal shaft are drained by the deep dorsal and the preprostatic plexus, while the proximal portion is drained by the cavernous and crural veins to the preprostatic plexus and internal pudendal vein. In skin and subcutaneous tissue, multiple superficial veins run subcutaneously and unite near the root of the penis to form a single or paired superficial dorsal vein which drain into the penis vein.
And
Innervation.
back to the venous drainage. Just because of this complex venous drainage of the venous and the arterial drainage, arterial supply of the penile, it is very crucial to know that what kind of arterial sufficiency lead to the erectile dysfunction, or through which channel the venous leakage occurs. As we can see that there is the three system: the superficial system, the intermediate system, and the deep system. The superficial is the external pudendal and the superficial vein. That is the superficial जो कि drain कर रही हैं. जो intermediate हैं, that is the circumflex and the deep dorsal, and both of them going to be drained in the right pudendal and the left pudendal, which itself going to be drained in the cavernous and the and then form the retropubic venous plexus. So when we are going to do the cavernosography, which is the CT cavernosography, in which we are going to do for the venous leakage. So it has to we should know the anatomy of this venous supply to know that which part and from which the side venous leakage occur, and which is draining to the venous leakage draining to which vein, like the penis vein, femoral vein, or it could be superficial or it could be deep.
Nerves. Autonomic pathway, lumbar splanchnic nerves, inferior mesenteric and superior hypogastric plexus, hypogastric nerves to pelvic plexus. Sympathetic innervation to penis from T12 to L2 segment, detumescence, control ejaculation. Parasympathetic innervation S2 to S24, tumescence, somatic nerves, sensory and motor, are primarily responsible for sensation of penile skin, glands, urethra within the corpus cavernosum. Free nerve ending A and C fiber, thinly myelinated dorsal nerve, penis pudendal nerve S2 to S4. On-off nucleus, center of somatomotor penile innervation localized to S2 to S24. Tunica albuginum.
A little bit word about the vascular and the innervation point of view, that these are the 2 points that initiate the tumescence and the detumescence, responsible for this. So we have to know the clear anatomy of these two things, the vascular supply and the innervation, because whatever the treatment you are going to give to the patient is entirely depend on these things. So correctly said that this is the parasympathetic innervation that leads to the tumescence, and the tumescence, and the sympathetic for the detumescence. But with the initiation of the ejaculation, the tumescence is started, while the parasympathetic initiate first to create the tumescence.
Tunica albuginea. Outer layer of tunica collagen bundles are oriented longitudinally, extending from the glans penis to the proximal crura. They insert into the inferior pubic rami but are absent between the 5 and the 7 o'clock position. In contrast, the corpus spongiosum lacks an outer layer or intracorporeal struts, ensuring a low pressure structure during erection. The outer tunica layer appears to play an additional role in compression of the emissary vein during erection. Its main function is to attach the tunica albuginea of the corpora cavernosa to the pubis, and it provides support for the mobile portion of the penis. Congenital deficiency or at whom this ligament has been severe in penile elongations, surgery, the erect penis may be unstable or drop. Fundiform ligaments is lateral, superficial, not adherence to the tunica albuginea of the corpora cavernosa. Two lateral bundles and one median bundles which circumscribe the dorsal vein of the penis. Hemodynamics and mechanism of tumescence and tumescence. Phases of erectile process. Flaccid phase. Cavernosal smooth muscle, contracted sinusoids, empty, minimal arterial flow. Latent filling phase. Increased pudendal artery flow, penile elongation. Tumescent phase. Rising intracavernosal pressure, erection forming. Full erection phase. Increased cavernosal pressure causes the penis to become fully erect. Rigid erection phase. Further increase in pressure plus ischio-cavernous muscle contraction. Detumescence phase, initial slow and fast phase. Following ejaculation, sympathetic discharge resume. There is smooth muscle contraction and vasoconstriction, reduced arterial flow, blood is expelled from sinusoidal spaces.
So, if I may add that the start of the tumescence is started not only the level of at the level of smooth muscle, it is the molecular level. Next, please. So, if
Molecular.
we can appreciate it, let me. If we can appreciate it, there are there are the modulators, that is the nitrous oxide, VIP, PGE1, that initiators, and some of the inhibitors like noradrenaline and PGF2. So what they do is that the initiation of the erection occurs when the nitric oxide synthesis actually that acts on the endothelial nos receptors on the nervous system and the endothelial system, that is the vascular system. What they do that it break guanylyl cyclase in the enzyme that break the GTP into the cyclic GMP, which further what they do that the hydrolyzation of the potassium occurs. That leads to the influx of the potassium in the cell and the efflux of the calcium outside of the cells. Mean that if the intracellular calcium is decreases, hence the smooth muscle relaxation is occurs and the erection. With the going back, so at that moment when the relaxation of the muscles is takes place, the dilatation of the arterioles and arteries increase blood flow, further causing the rigidity and the tumescence of the penis, and that causing the trapment of the subtunical venous plexus in between the tunica albuginea and the peripheral sinusoids. Further, the system when it's enhancing, then there is the second pathway, that is the adenylyl cyclase pathway, that again because of the same neurotransmitter break the cyclic ATP into the AMP with the same adenylyl cyclase enzyme, leads to the further intracellular calcium को सेल में डिक्रीज करवाता है and the further tumescence increase कराता है, and it will lead to the increase of the partial pressure of oxygen up to the 100 mercury, that leads to the erection of the penis. And with this when this all of the stimuli will or the ejaculation occurs, the detumescence arises with the same with the other pathway and the other modulators, that is I again mentioned in the next slide, which leads to the detumescence by the ejaculation, that is the sympathetic system of the system of the nervous system.
Erectile dysfunction. Erectile dysfunction is defined as persistent inability to attain or maintain an erection sufficient for satisfactory sexual intercourse, previously called impotence. Prevalence of erectile dysfunction. 1 in 5 men lifetime. This overall prevalence rate of men over 19 is 18.4%. Prevalence and risk factor for erectile dysfunction, the US American Journal of Medicine. Machisto male aging study, incident of erectile dysfunction 1987 to 2004, 20 to 39 years old is 10 to 20%. 40 to 59 years old, 30 to 55, 50%. 60 to 79 years old, 60 to 80%. 80 years old and older is 79 to 90% erectile dysfunction.
So with this study,
48%.
sorry. So with this study, there are the through it's a very big study that is conducted from 1987 to 2004. It is published in 2000, and it was the biggest study. It enumerates the two things. One is the age-wise incidence of the erectile dysfunction, various causes that leads to the different decades in life of a man that leads to the erectile dysfunction, and overall the if the ED occurs, then how much percent its degree? Like 17% is the minimal from out of 50 to the 70% patient prevalence is the minimal erectile dysfunction. 25% was moderate and 10% having a severe or the complete erectile dysfunction. And furthermore, if we just elaborate and see that there are the further decades like 20 to 39, 10 to 20% of the male do experience in their life the erectile dysfunction. Although the causes of the erectile dysfunction in this decade is completely different from the 40 to 59 and then 60 to 79 and then 80 plus.
Classification of erectile dysfunction: psychogenic, organic. Psychogenic, sudden onset, complete immediate loss, situational dysfunction, walking erection present. Organic, gradual onset, incremental progression, global dysfunction, walking erection, poor absent. Organic, vasculogenic, arteriogenic, cavernosal mix. Neurogenic, anatomic, endocrinologic. Psychogenic, generalized, a generalized unresponsiveness, primary lack of sexual arousability, aging related decline in sexual arousability, generalized inhibition, chronic disorder of sexual intimacy. Situational, a partner related lack of arousability in a specific relationship, lack of arousability owing to sexual object preference, high central inhibition owing to partner conflict or threat, performance related associated with sexual dysfunction, rapid ejaculation, situational performance anxiety, fear of failure, psychological distress or adjustment related associated with negative mood, depression, or major life stress, death of partner. Etiology: chronic disease, diabetes, prostate disease, peripheral vascular disease, cardiac problems, hyperlipidemia, hypertension.
So
All the
these are the comorbids with the references given of the journals in which these articles are published, which either knew the prevalence of these chronic diseases leads to the risk factors. That is the diabetes that leads to the risk factor, enhance the risk factor of the erectile dysfunction by 4x. And hypertension is the second one, which leads to the erectile dysfunction. That is the 1.6 percent increases the risk factor of the erectile dysfunction. Along with that, there is several causes. We just knew that there's the organic cause, that is the vasculogenic, that is the neurogenic, that is the other mixed type or the anatomic type, the endocrinological type. So this is the elaboration of these causes, like the inflammatory processes leads to the prostatitis, and that can lead to the or the prostate disease that can lead to the erectile dysfunction. In the mechanical cause or the anatomical cause, the Frenuy's disease is one of the leading cause due to which the erectile dysfunction occurs. Priapism is the second one, but not the most common one. In psychological one, there is the various drugs that used, which leads to the erectile dysfunction. That the mechanism and the pathophysiology is that it causes the impaired nitric oxide release, and the loss of libido and sympathetic nervous activation is also disturbed because of these by taking of these either the psychological orders with the psychological orders. The oculovascular disease or the factors, that is the hypertension, atherosclerosis, and other arterial insufficiencies, or the hyperlipidemia or the diabetes mellitus, all they are going to do the impaired vasculature, inadequate arterial inflow. Uh, if you are going to take any kind of a specific drug, most of the drugs, just like it's mentioned in this, like the chemical antihypertensive, antiarrhythmias, and the other kind of the drug, like suppose the digoxin, that leads to the blockade of the potassium and the sodium ATPase channel, which leads to the increase in the intracellular calcium, जो कि पहले हमने डिस्कस किया था कि अगर इंट्रासेलुलर कैल्शियम सेल में जैसे ही कम होगा, दैट विल लीड टू द relaxation of the smooth muscle and the tumescence will occurs. Same for going for the patient, if they are going to take the antihypertensive drugs, this leads to the low blood pressure, which is the जो इनिशिएशन करने के लिए जो ब्लड फ्लो का इंक्रीज होना, प्रेशर का इंक्रीज होना जरूरी है, वो इसी वजह से कम रहता है. इस वजह से दैट कैन लीड, वन ऑफ द मेन कॉज भी हो सकता है फॉर द पेशेंट हु आर टेकिंग द एंटीहाइपरटेंसिव ड्रग्स फॉर द इरेक्टाइल डिसफंक्शन.
Patient who seek treatment for erectile dysfunction have a high prevalence of cardiovascular disease. Men with erectile dysfunction should be screened for cardiovascular risk factor cost benefit consideration. Based on consistent men with no non-cardiac disease, the guidelines suggest screening for cardiovascular disease risk factor including coronary artery calcium, exercise capacity categorized as low, intermediate, or high risk, and the patient can be further assessed accordingly.
So in the guidelines, it just included, previously it was the 2 and 3 consensus, so which have a different type of the guidelines that need to be followed, and now in the Preston 4 and the recently EUA guidelines, it is saying that patient जो आपके पास आए, उनके पास अगर कोई cardiac history ना हो, तो उनको तो जरूर आपने screen करना है for the cardiovascular risk factors के लिए, because it has a very high prevalence rate of having ED. The underlying cause of the patient may have cardiovascular disease, and this is a chart through which you are going to screen your patient, like if they are asking for the ED symptoms, and if they had, so आपने पहले सस्पेक्ट करना है कि उसमें वेस्कुलरजेनिक कोई मैकेनिज्म है या नहीं है. अगर है तो आपने उसको करेक्टिसाइज करना है कि भाई ये लो रिस्क है, इंटरमीडिएट रिस्क है या हाई रिस्क है, as it can show is showing that 5% do have a low risk, 5 to 20% have an intermediate risk, while high risk having a 20%, more than 20%. The intermediate risk और जो भी होंगे उनको अपने कोरोनरी आर्टरी कैल्शियम स्कोरिंग पे जाना है. दिस इज अ सीटी स्कैन थ्रू विच इट लेबल दी कोरोनरी आर्टरी में एथेरोस्क्लेरोसिस कितनी है, तो वो उस पे इसको स्कोर करते हैं, और अगर इसका ग्रेटर देन 100 है तो उसके साथ में आपने पेशेंट को जो है क्या क्या आपने सजेस्ट करना है, तो उसके हिसाब से ये गाइडलाइन को आपने फॉलो करना है.
अच्छा, मुझे क्लियर नहीं हुआ. व्हाट आर द इंडिकेशन ऑफ कैक स्कोरिंग इन इरेक्टाइल डिसफंक्शन पेशेंट? When you will do the CAC scoring?
There is the risk enhancing factor है, जो कि आपने क्वेश्चनर के तौर पे और पेशेंट से डिस्कशन करके आपने जो है वो इसमें रिस्क स्ट्रैटिफिकेशन करनी होती है पेशेंट को, जिसके बाद जो है वो
किन पेशेंट्स को करनी होती है, मुझे समझ नहीं आ रही है. नहीं, there should be
आपके पास अगर कार्डियो आपके पास इरेक्टाइल डिसफंक्शन के साथ आएगा, उसको आपने एक्सेस करना है इफ द पेशेंट डू हैव अ वेस्कुलोजेनिक मैकेनिज्म, और उन पेशेंट में अगर है तो उनको जरूर आपने स्क्रीनिंग करना है. जैसे कि हम पहले भी बात कर रहे थे, अगर इनमें कोई कार्डिक डिजीज नहीं है, जैसे पेशेंट अपनी हिस्ट्री दे रहा है कि मेरे पास कोई कार्डिक हिस्ट्री नहीं है, मैं कोई दवाई नहीं लेता, मेरे लिए कोई मसला नहीं है, तो उसमें आपने इनको जरूर स्क्रीनिंग करनी है उन पेशेंट्स में जरूर, कि अगर वो वेस्कुलोजेनिक या वीनोजेनिक मैकेनिज्म से आपको लग रहा है कि आप सस्पेक्ट कर रहे हैं कि इट कुड बी द कॉज ऑफ ईडी, उन पेशेंट में आपने इन पेशेंट्स के लिए जरूर स्क्रीनिंग करानी है कि आप अपना एक कार्डियोवैस्कुलर स्क्रीनिंग करवा के लेके आए. I hope now.
To simplify,
please, yes.
Nazish is right that if the patient have vasculogenic ED, then we have to do the CAC scoring. Another indication is that if the patient have the patient come with the less than 50 year and there is a erectile dysfunction and there's a history of diabetes, hypertension, smoking, then we have to do the CAC scoring, and we have to categorize the patient according to the CAC scoring. Okay, and also, if the patient have ED and multiple metabolic syndrome like obesity, insulin resistant hypertension, and dyslipidemia, so these are the indication of CAC scoring in erectile dysfunction patient. Okay, thank you very much.
Thank you, sir.
समझ आया किसी को? कोई सीनियर रेजिडेंट एक दफा बता दे. दानिश बहुत अच्छा.
Sir, first of all, if there is an obvious cardiovascular risk, affected present, and then we will be doing a CAC scoring. And other than that, if a patient presents with ED in less than 50 years of age and having co-morbs like diabetes, hypertension, insulin resistance, then we should go for CAC scoring. Thank you.
Diagnostic evaluation of men with erectile dysfunction guidelines. Patient with erectile dysfunction self-reported. Medical and psychosocial history used for validated instrument. International scoring of erectile function. Identify other sexual problems, not erectile dysfunction. Identify common causes of erectile dysfunction. Identify reversible risk factor for erectile dysfunction. Assess psychosocial status. Focus physical examination. Penile deformities, prostatic disease, sign of hypogonadism, cardiovascular disease. Laboratory test. Glucose lipid profile if not assessed in the last 12 months. Total testosterone level. History. Sexual history, sexual orientation, previous and current sexual relationship, current emotional status, onset and duration of erectile problems, and previous consultation and treatment. Self-stimulation stimuli used during intercourse, erection on awakening, sexual desire, arousal, ejaculation, and orgasm. Medical history, diabetes mellitus, cardiovascular disease, hypertension, dyslipidemia, hypogonadism, thyroid disorder, spinal cord injury, pelvic surgery, pelvic radiation, Parkinson, renal failure, schizophrenia. Other age, alcohol, cigarette, smoking. Questionnaire. Self-administered erectile dysfunction questionnaire are extremely useful adjunct to the case history. Serve in documenting the presence and severity of erectile dysfunction and the responsiveness of erectile dysfunction to treatment. The most widely referenced include the International Index of Erectile Function. Psychological history and evaluation. Occupational status, financial security, family life, social support, depression, anxiety disorder, personality disorder, fear of failure, performance anxiety for widower. This may include complex interaction of dating new partner and unresolved morning girl. Insufficient sexual stimulation, loss of attraction for the partner, adjustment to a chronic illness or surgery, and relationship conflicts, unresolved parental attachment, sexual identity issue, history of trauma, occurrence of extramarital affairs, and cultural religious taboo.
So when you are going to know and taking the history, so as we know that there is the organic type and then the psychological type. So you need to take the thorough history of if the patient, because you are going to evaluate the patient that he's suffering from ED because of psychological disease or any kind of the organic disease. So first of all, the comorbids, the age, and then the this questionnaire will help you to scoring the erectile dysfunction, but not the cause of the erectile dysfunction. And along with that, the history not just because of the patient, but also from the partner as well. Because sometimes the patient do think of themselves that this is the problem. The partner may do not think so. The partner thinks so, and he didn't think so. So it does cause the thorough investigation will be needed after the thorough examination and the history.
Examination. Physical examination, height, weight, circumference, BP examination of relevant body parts pertaining to cardiovascular, neurologic, and particular focus on the external genitalia. Sign and symptom of hypogonadism, small testes, alternate secondary sexual characteristics, micropenis, epispediasis, hypospediasis, Peyronie's disease. Investigations.
So before proceeding to the investigation, I do want to ask from the residents there and here that there are some causes we just overlook some of them, that there are some surgical causes that will lead to the erectile dysfunction. So can anyone from there tell me that why the erectile dysfunction happens in after the radical prostatectomy? Habib, you can ask from there. I cannot see the residents there. From here?
Dr. Zakaulat.
Huh?
Dr. Ali.
Cause of the nerve injury, which nerve? Anyone from there? So here.
I think cavernosal nerves which are present there while doing a prostatectomy, they can be damaged. So
yes. And because of this, the nerve sparing of the radical prostatectomy and the evaluation of innovation of this technique can take place. Here, Dr. Safir and the resident is correct. Then kindly do tell me that why the in DVIU the erectile dysfunction occurs. The direct optical internal urethectomy.
In DVIU, if there are risks injury to the covered nozzle bodies. If we do it inappropriately, means if there is more incision at 12 o'clock, then there are and if it is not at proper place, like in bulbar urethra where the urethra is eccentric, then there are risks to injury to the cardboard bodies, and there is then chances of venous leak while erection cannot be maintained after that.
Yes, correctly said that it causes the shunt in between the urethra and the cavernosum. And if it's not placed, I do remember that in one our session, Dr. Tanzil do tell us that that the correct position for the internal urethrotomy on the diaphragm. I do remember that. So the last question is that in the post-transplant patient, why is it occur? If most of the time it correct the previously the uremic conditions in the patient with the renal failure, the erectile dysfunction is one of the cause is do happens, but after the transplantation it does correct, but in some cases the post transplant the ED occurs. Why it does occur? The surgical cause. So it's anyone is there or so it's because of the anastomosis and the type of the anastomosis that you are going to do in the transplant. That is the occlusion. If the internal iliac artery occlusion occurs, that is the end-to-end type of the anastomosis. If you are doing the in the transplantation of the renal, it may lead to the erectile dysfunction. But if there is a side-to-end with the external iliac artery anastomosis is you are doing for the renal transplantation, then the erectile dysfunction is not frequently occur. So this is the cause. Okay, you can carry on now.
Investigations: complete blood count, serum chemistries, fasting glucose or HbA1c, lipid profile, total testosterone measure from morning time blood draw, prolactin measurement, thyroid function test, prostate specific antigen, divistic analysis of urine may show glycosuria, which suggests diagnosis of diabetes. Serum testosterone measurement. Testosterone circulates in three fractions: free 0.5 to 3%, tightly bound to sex hormone binding globulin 30%, and loosely bound to albumin and other serum protein 67%. Free testosterone and albumin bound portion make up the bioavailable testosterone fraction. The relative concentration of the carrier protein and albumin modulate androgen function. Serum gonadotrophin measurement. Measurement of serum gonadotrophin help to localize the source of the hypogonadism. Testosterone release involves the integrative activity of the hypothalamic pituitary gonadal axis and its regulatory feedback mechanism. And disruption at any level of this axis may account for hypogonadism. Primary hypogonadism: low testosterone, decreased negative feedback to the hypothalamus and pituitary, increased secretion of LH and FSH. Secondary hypogonadism: normal or low serum luteinizing hormone and follicular stimulating hormone with low serum testosterone level and central disorder. Serum prolactin measurement. Hyperprolactinemia, whether from a pituitary adenoma or drugs, result in both reproductive and sexual dysfunction. Hyperprolactinemia is associated with low circulating level of testosterone due to suppression of gonadotropin releasing hormone. Also impair luteinizing hormone secretion required for testosterone production.
So when you are going to for this hormonal workup, you should know how to interpret it. So if someone suffering from the primary hypogonadism, then there is the low testosterone levels, while the FSH and FSH would be increased also. So FSH अगर प्राइमरी होगा तो फिर FSH और LH इंक्रीज हुआ होगा, while the testicular failure में होगा तो वहाँ पे आपका testosterone levels कम हो सकते हैं. The secondary would be due to the in which the all of the hormones would be decreased, and the seminiferous tubules अगर उसमें होगा जहाँ पे it was going to act on it, then there's the FSH यानी कि will be increases, and the testosterone and LH levels would be normal. So you need to know कि आपने जब भी किसी को अगर टेस्टोस्टेरोन लेवल्स, फर्स्ट ऑफ ऑल द फर्स्ट लाइन थेरेपी आप करवाएंगे, अगर किसी में हाइपोगोनेडिज्म सोच रहे हैं कि इसमें हो सकता है, तो पहले उसमें तो देखना होगा कि लॉस ऑफ लिबिडो कैसी है, पिनाइल साइज कैसा है, या पिनाइल की डिफॉर्मिटी तो कोई ऐसा नहीं है जहाँ पे आपको सेकेंडरी सेक्सुअल कैरेक्टरिस्टिक्स नहीं सही तरह से डेवलप हुए हों, या फिर वो फीमेल की तरफ दिखा रहे हैं, जैसे कि ग्लैक्टो वो पेशेंट को जो है हाइपोमैस्टिया होता है, सॉरी गैनकोमैस्टिया होता है, या इनफर्टिलिटी है, तो उन पेशेंट्स में आपने इनको फर्दर हार्मोनल एसेस को आपने करवाना है.
Serum thyroid function test. Hyperthyroidism is associated with erectile dysfunction. Hyperthyroidism, diminished libido, increased aromatization of testosterone into estrogen, increasing adrenergic tone. Hypothyroidism, low testosterone secretion and elevated prolactin level contribute to erectile dysfunction. Specialized evaluation and testing. Primary erectile dysfunction not caused by organic disease or psychogenic disorder. Young patient with a history of pelvic or perineal trauma who could benefit from potential curative revascularization surgery or angioplasty. Patient with penile deformity which might require surgical correction, Peyronie's disease, congenital penile curvature. Patient with complex psychiatric or psychosexual disorder, patient with complex endocrine disorder. A specific test may be indicated at the request of the patient or his partner. Medical legal reason, implantation of penile prosthesis to document and stay erectile dysfunction, sexual abuse. Nocturnal penile tumescence rigidity using Regiscan. Vascular study, intracavernous vasoactive drug injection, penile dynamic duplex ultrasonography, penile dynamic infusion cavernosometry and cavernosography, internal pudendal arteriography, neurological studies, endocrinological studies, specialized psychodiagnostic evaluation. First investigation, combined intracavernous injection and stimulation. It involves intracavernous injection of a vasodilatory drug or as a direct pharmacological stimulus, combined with genital and audiovisual sexual stimulation, and the erectile response is observed and rated by an independent assessor. A normal CIS test based on the assessment of a sustainably rigid erection is understood to signify normal erectile hemodynamics. A rigid erection within 10 minutes and lasts for 30 minutes is indicative of normal. False positive result may occur in 20% of patients with borderline arterial inflow as defined by the measurement of 25 to 35 cm peak. Cavernous arteriostolic flow and diastole ultrasonography. False negative result.
This test can exclude the veno-occlusive dysfunction, but not the arterial insufficiency. So we need, if we are going to suspecting for the venogenic cause, then there is the further evaluation of the test we are going to do.
Psychophysiologic evaluation. Penile tumescence and rigidity monitoring. It measures the number of episode tumescence circumference changed by strain gauges, maximal penile rigidity, and duration of nocturnal erection. Normal NPTI include 4 to 5 erectile episode per night. Assessment should be performed on at least 2 separate nights.
And it's basically for the psychogenic kind of the erectile dysfunction or the psychological erectile dysfunction के लिए ये वाला जो test है वो होता है. If the patient is suffering from the psychological erectile dysfunction, it would be normal occurrence of the erectile episodes will occur.
Duplex ultrasonography, reliable and least invasive. Color-coded duplex ultrasound indicate the direction of blood flow within vessels, with red designating direction toward the probe and blue designating direction away from the probe. Dynamic infusion cavernosometry and
पीछे करें. So interpretation of this is utmost important. How you are going to do that? You are going to do the inject 20 micrograms of the alposterol or the PGE1 stimulator for the ऑफ द इरेक्शन के लिए जो करते हैं कॉर्पस कैवर्नोसा में इंजेक्ट करेंगे, उसके बाद उसमें रिजिडिटी आएगी। इसके 4 to 4 फेजेस होते हैं, और जिस भी फेज में पिट्यूमेसेंस आता है, फॉर हाउ लॉन्ग इट्स गोइंग टू बी टेक, तो उसको आपने मेजर करना होता है। हाउ टू इंटरप्रेट इट, दैट इट हैज अ नॉर्मल वैल्यू, दैट इज अगर पीक सिस्टोलिक वेलोसिटी इफ इट्स ग्रेटर देन 30 सेंटीमीटर पर सेकेंड होगी, या एंड डायस्टोलिक वॉल्यूम लेस देन 5 सेंटीमीटर पर सेकेंड होगी, या इन दोनों में जब आप इसको रेजिस्टिव इंडेक्स निकालेंगे दैट कुड बी मोर देन 0.9 के से होगी, देन इट वुड बी लेबल एज अ नॉर्मल। इफ द पेशेंट इज सफरिंग फ्रॉम द आर्टेरियल इनसफिशिएंसी, तो उसमें या तो माइल्ड डिग्री हो सकती है या मॉडरेट हो सकती है। अगर मॉडरेट है दैट इज लाइक कि अगर 25 सेंटीमीटर पर सेकेंड से अगर कम हो जाएगा, दैट इज द आर्टेरियल इनसफिशिएंसी, आप उसको लेबल कर देते हैं। अलॉन्ग विद दैट, अगर तो पेशेंट उसके साथ में एंड डायस्टोलिक वेलोसिटी भी उसकी अगर मोर देन 5 सेंटीमीटर है, तो इट वुड बी लेबल्ड एज अ मिक्स्ड आर्टीरियल और मिक्स्ड वीनोजेनिक डिसफंक्शन, आप उसको लेबल करेंगे। और अगर सिर्फ एंड डायस्टोलिक वेलोसिटी इज ग्रेटर देन 5 सेंटीमीटर पर सेकेंड विद द रेजिस्टिव इंडेक्स अगर उसमें 0.5 से कम होगा, तो उसको भी हम वीनो ऑक्लूसिव डिसफंक्शन में पेशेंट को label करेंगे, and then further evaluate for the venous leak if occurring at which level.
Dynamic infusion cavernosometry and cavernosography indicated for patients who are suspected to have a site-specific vasculogenic leak resulting from perineal or pelvic trauma, or who have had lifelong erectile dysfunction. Primary erectile dysfunction. Existence of veno-occlusive dysfunction is indicated by the failure to increase intracavernous pressure to the level of the mean systolic blood pressure with saline infusion, or the demonstration of a rapid drop of intracavernous pressure after cessation of saline infusion.
So a bit word for the cavernosometry, पीछे how you are going to conduct it is it's a bit invasive procedure in which you are going to inject 2 needles in the corpora cavernosa, one for the injecting heparinized saline, the one for the injecting for the erection, to induce the erection. So you are going to flow the heparinized saline in the corpus cavernosa with the pressure of about 30, 60, 90 and 150 mm mercury. It was going to be sustained up to the 150 mm mercury, and then the cessation of the infused volume would occur. If there is the decay of 45 mm mercury occur in 30 seconds, it will label as the venogenic leak or the venous leak. Or if there's a flow to maintain, like when you seize the infused volume for that volume is going to be seized, and then the pressure was decreasing and the fused volume you are going to maintain it. If it's greater than 3 ml per minute, then it's also going to be labeled as the venous leak. So this is all about the cavernosometry. The other thing is the cavernosography. If we do have a
Cavernosography.
minute, then we I would like to show the video of it, which is quite informative, and if we don't have, then we will share the link so everyone can see this. Okay.
It is Dr. Vasim Mehmet. I'm a radiology resident from Alpha University Hospital.
Please
So
speak.
coming towards background, the imaging helps out to rule out underlying conditions that may cause erectile dysfunction. Imaging for erectile dysfunction provides critical information for diagnosis and also serves a role in ongoing surveillance and treatment response and prognosis. In patients with suspected veno-occlusive dysfunction on duplex ultrasound, CT cavernography should be performed for morphological depiction of venous leaks in the absence of sufficient penile rigidity. This is crucial for adequate patient selection for endovascular treatment. So coming towards a few words about duplex ultrasound. So the color Doppler flow analysis using the pharmacological stimulation with intracavernosal injection of prostaglandin E1 is performed and in a patient with organic erectile dysfunction. So the diagnostic criteria for the veno-occlusive dysfunction are high systolic flow rate greater than 25 centimeter per second, peak systolic velocity, and a persistent and diastolic velocity of greater than 5 centimeter per second, 15-minute post injection, that is the rigid phase, with a resistive index of less than 0.75. So after doing this duplex ultrasound, the patient with suspected veno-occlusive dysfunction based on the ultrasound, duplex ultrasound parameters that are high and diastolic velocities. So the dynamic cavernosometry and cavernosography are the accepted gold standard for the diagnostics, and the dynamic cavernosometry requires pharmacological stimulation with intracavernosal injection of prostaglandin E1 in order to obtain a rigid erection. Subsequently, fluid is injected into the penis using certain rates and pressures in order to obtain information about the change of pressure within the corpora cavernosa during penile erection. For cavernosography, contrast medium is injected to visualize potential venous leak on venogram during penile erection. So a 21 gauge needle is inserted into the corpora following in the intracavernosal injection of 20 microgram prostaglandin E1 after 30 minutes of intracorporal power injection of 120 milliliter of 50% solution of non-ionic contrast agent is performed with the flow rate of 2 milliliter per second. So on cavernosography, the potential sites of venous leakage can be identified. So these may be in the deep dorsal vein, in the cavernosal vein, internal pudendal veins, periprostatic plexus, external pudendal veins, or iliac veins. Diagnosis confirmation of veno-occlusive dysfunction includes demonstration of the venous leakage on cavernosography and associated absence of sufficient penile rigidity. So coming towards the CT cavernosography, in case of positive findings of veno-occlusive disease in duplex ultrasound, additional CT cavernosography should be performed to morphologically demonstrate leakage of penile veins. CT images, especially deformative data using MPR and MIP volume rendering techniques in order to depict details of venous leakage, including penile veins, origin of crural veins, periprostatic venous plexus, pudendal veins, and drainage into iliac or femoral veins. So penile drainage can be divided into three groups. First is superficial veins, then intermediate veins, and then the deep veins. The type of the deep veins and the periprostatic venous plexus.
I think you should stop here because we have got no time. It's 9 o'clock.
Okay.
Okay, sir.
Just come to the conclusion.
Okay.
Come to the conclusion.
The end slide for the guidelines.
EUA guidelines recommended for the diagnosis of erectile dysfunction. Take a comprehensive medical and sexual history in every patient presenting with erectile dysfunction. Consider psychosexual development, including life, stressor, cultural aspect, and cognitive thinking style of the patient regarding their sexual performance. Use a validated questionnaire related to erectile dysfunction to assess all sexual function domains, International Index of Erectile Function, and the effect of a specific treatment modality. Include a focused physical examination in the initial assessment of men with erectile dysfunction to identify underlying medical conditions and comorbid genital disorder that may be associated with erectile dysfunction. Assess routine laboratory tests including glucose and lipid profile and total testosterone to identify and treat any reversible risk factor and lifestyle factor that can be modified. Include a specific diagnostic test in the initial evaluation of erectile dysfunction in the presence of the condition present in the
A thorough history and evaluation with the sense of mind that this is the complex, having a complex vascular and innovation. And because of that, the multiple comorbidities can be involved in the erectile dysfunction. So just treating the erectile dysfunction is not enough, but the cause of it also. So I'm ending the presentation here. Thank you, Dr. Habib, for such a good presentation. And sir, do you want to add some conclusion?
No.
Thank you. And thank you. Any question and questions?
Thank you. Thank you, sir.